Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. This is part 5 of a 5-part series on alveolar-focused orthodontics, visualization of limitations of orthodontic tooth movement through cone beam CT. My name is Jeffrey Miller. I graduated from Towson University, got my dental education at University of Maryland, my orthodontic certificate at State University of New York at Buffalo, board certification in 1991. I've been in private practice in the Maryland area for over 33 years. I'm a member of the Golden Circle of Excellence, and I speak on cone beam CT topics related to orthodontics. Cone beam CT allows for visualization of limitations of orthodontic tooth movement by being able to look at individual teeth and their supporting bone. As orthodontists, we should be mindful of the underlying bone anatomy that supports the teeth. This is a 48-year-old female patient that was being treated orthodontically by her general dentist using Invisalign. He wasn't making very much progress on the case, so we referred it to our office. First thing I did was I got his login and password, and I looked at his CliniCheck account to see what the proposed treatment plan was. Now it turns out she made no progress because she never wore the trays. She was not compliant. And here is the treatment plan that Invisalign had proposed. It's interesting, they did this with 15 trays. This is the existing malocclusion or the current malocclusion, and this is the virtual simulated result. They used 15 Invisalign trays. They did not use any interproximal reduction, nor did they extract, and he paid extra to use a service called Invisalign Assist. Invisalign Assist is where Invisalign comes in and helps you treatment plan the case, and this is what the proposed treatment looked like. Because the lower anterior region is the most sensitive or the least maneuverable orthodontically, we have the thinnest bony housing there. I'm concentrating mostly on the lower arch in this case. Here you can see what they did. Here's the original malocclusion, and here's the virtual simulated result. You can see all they really did was just some expansion to align these teeth. Here is the superimposition through CliniCheck. Here you can see the blue is the original malocclusion, and the white is the virtually simulated result. Now keep in mind that with CliniCheck, you're really only maneuvering clinical crowns. There's no consideration for the underlying bone anatomy or the root position. What I did was took a cone beam CT, I uploaded it to Orthodontics. Orthodontics produces a 3D reconstruction where the bone modeling is accurate within 0.2 of a millimeter, and they have plenty of documentation to support that. When you simulate treatment using the Orthodontics model, you see the result of the tooth and the bony housing. I would say the one shortfall of this type of simulation is that you don't see the slight modification to the interseptal bone as you start to dehiss the root. And I'll explain that in a second. I uploaded the cone beam CT to a service called Orthodontics. Orthodontics allows for treatment simulation using the data from the cone beam CT. So when you simulate treatment orthodontically using the Orthodontics software, you see the result of the root and the bone. What I did was I used the Orthodontics software to mimic the treatment that was recommended by Invisalign. So here you can see the Invisalign proposed virtual treatment, and here is the proposed virtual treatment using Orthodontics. Now remember, with Orthodontics, you're seeing the position of the roots and the bone as well. With CliniCheck, you're really just manipulating clinical crowns. You really have no idea where the root and the bone ends up. Here's the superimposition using the virtual simulated treatment from Invisalign, and here is the duplicated treatment using the Orthodontics software. And I think if you look, they're pretty close. If anything, I use maybe a little less expansion than CliniCheck, but very, very close. And you can see the light green is the original malocclusion and the white is the virtually simulated result. Because Orometric software is using a DICOM file from a cone beam CT, you get to see the alignment of the roots as well. And if you look at the alignment of the roots, these look pretty good. They look good until you put the bone layering on. Once you put the bone layering on, you can see the boundary violations or the dehiscence associated with that proposed treatment. Now, this model does not show the interseptal bone changes that would be likely to occur if you violated the facial cortical plate as in this proposed treatment, but that's not really that significant. Here is a cross section of that tooth. This patient, with this proposed treatment, lost about 60% of their total root bone coverage. You add in the interseptal changes, so maybe they lost 40 or 50%. That's still not good. That's probably not a treatment plan that you want to do. I got this slide from a buddy of mine that's an orthodontist in Florida. This was an Invisalign case that was being treated. This patient is still under treatment based on this attachment still being present. And you can see that this treatment is probably very similar to the proposed treatment that was recommended for this patient we're discussing. And this tooth, you can see, was pushed out past the limit of the cortical plate. Also, because it was pushed out and probably this treatment's probably going on for a while, they got adaptive resorption of that lingual bone. So now if you want to try to correct it, there's really be difficult to get that tooth centered back over the bone. I simulated treatment using a fairly aggressive interproximal reduction scheme. This certainly looks better. This would be difficult to do, however, without round tripping the teeth first. I also simulated treatment using a lower extraction. Based on the underlying Bolton discrepancy, I thought this was the better treatment plan. It kept the lower incisors centered within the alveolar process the best. You need to also check these from the lingual. You can perforate through the lingual just as easy as you can perforate through the facial. Here's the patient a year post active orthodontic treatment. You can see the teeth are fairly well aligned. You don't see any dark triangles here because we closed the space fairly quickly using fixed appliances. Here's a post-treatment cone beam CT. You can see from the sagittal view the tooth looks fairly well centered, but really you need to look at the axial view to see if there's any significant dehiscence associated with any of those incisors. And that looks, probably as good as it's going to look. Here, just comparing, here's the virtual simulation that I did prior to starting treatment, and here is the actual cone beam 1 year post active orthodontic treatment. You can see they're very, very close. So when you focus on the alveolar process versus focusing on clinical crowns or cephalometric standards, you come up with a different treatment strategy sometimes. And sometimes it doesn't matter, but in certain cases, if your priority is to try to keep the teeth centered within the alveolar process, your treatment plan may change. You never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. And I believe that's exactly true when you compare cephalometrics with cone beam CT. And that quote is from Richard Fuller. Thanks for listening. Certainly if you have any questions, you feel free to contact me. My email is drmiller@orthodonticassoc.com. Thanks.